So why don't we wait 2 minutes and
Okay, just
Gary, I'm sorry.
I'd like to formally introduce myself. This is the first time I've met you all. My name is Stephen Kaufman. I've been working with Sandy Bloom for several years in several projects, and I appreciate the opportunity to participate in today. Just wanted to give a quick hello to everybody on that. So,
thanks, Steve.
Great to have you.
And if others want to, share who they are, what agency or organization they're with, and where they're calling in from in the chat, that would be great. As we keep letting people in.
Let's see, I can go next. Can you guys hear me?
Yeah.
I'm Terry Trafton, and I have worked with Marsha Morgan for many years and working on possibly what that relationship may look like in the future. And so I've never joined this before, but I'm very familiar with, CTIPP and what they've done. So I'm glad to be here today and learn about what you guys are talking about. Thanks.
Thanks so much. And for everybody else, if you want to use the chat box, Dan, we've got 93 people so far. So if you want to go ahead and get started.
Sure. Yeah, welcome everybody to the May CTIPP CAN call. My name is Dan Press. I'm the General Counsel and Director of Policy for the Campaign for Trauma-Informed Policy and Practice. We've been running these calls for about 2.5 years now, and we're getting a larger and larger audience. So thank you all for joining us. Before we get into our agenda, I want to ask for reports on 2 of our partners. First, I wanted to let you know, I've talked in the past about a group of legislators coming together who are advocating for trauma-informed legislation. They've now formalized their organization, and it's called Legislators Invested in Fighting Trauma, or LIFT. It's chaired by an assemblyman from New York and a Democrat and a Republican representative, a state representative from Oklahoma. So if you have any state legislators who are trauma advocates, let me know and I'll pass their names on so they can join LIFT. Then secondly, Tracy, do you want to give a report on the First Spouses Organization? I don't want to put you on the spot, but
that's nice of you, Dan. Thank you. I'm eating lunch, so it's probably best for all if I don't talk right now. But thank you very much. If you have any observations from the group, that would be great.
Okay. Today we have 4 incredible experts on a subject I think everyone on the call can relate to. How do you determine if your organization is trauma-informed, and how do you fill in the gaps? It's really critical. I just got off a webinar presented by the Trust for America Health, and they had a presenter from CDC who gave some just this devastating data that the year ending October 2020, there were 87,000 deaths from opioid overdoses, the highest there's ever been at any time. There were 97,000 deaths from alcohol abuse, again, the highest every time. There was a 30% increase in suicides over the period of the pandemic. It's just, the pandemic has just increased the trauma problems, and we need to do something about it. And having a trauma-informed organization is really critical. One also promotion for next month, we're going to have a bunch of 3 school superintendents talking about how they made their schools trauma-informed and the results they produced, which are really incredible, reducing suspensions by 80–90%, eliminating teacher turnover. And before we get into our presenters, Jesse will be talking about the fundings that's available through the Reform Act, but I want to focus on one portion of it. There's $122 billion going to local education agencies, and we put together a 2-pager that you could use to take you to your school board or your superintendent to encourage them to use a portion of that money to make their schools trauma informed, because we know following any major disaster, and the pandemic clearly qualifies, there's a huge increase in kids acting out in school, acting out their trauma, and the schools need to be prepared for it. Otherwise, they're really going to get hit hard. So Jesse, you're going to put the 2-pager or how to access it on the chat.
Yes, all of that is coming.
And we encourage you to reach out to your school boards, your school superintendents, your principals, and encourage them to use a little bit of that $122 billion to put something in place that will last for many, many years. And it's necessary because the trauma from the pandemic is going to last many, many years. So with that, I want to turn the mic over to Jesse, who will talk a little bit about the Reform Act and then introduce our wonderful host and moderator, Mimi Graham, the CTIPP board member, who will in turn introduce our presenters. Jesse?
So I will go very quickly. The first thing that I just did in the chat, above that is the first thing that I put in is the 2-pager that Dan was talking about. What I just put in the chat, that YouTube link, is an hour-long presentation that the National Trauma Campaign co-chair, along with myself, Marlo Nash, did to go deep into where the Rescue Plan Act funds are. I won't harp on it too much because we have such wonderful presenters today. I do want to make available for you, in addition to the education 2-pager, the parts of the act that have trauma-informed provisions or mental health provisions that can be advocated to use trauma-informed. And then here is a talking points document that can be leveraged, that again, we reference in the YouTube that I put in the chat. You know, there's a lot to talk about here. There is an opportunity to leverage mind-numbing amounts of money for trauma-informed purposes. We can't say that any of that will necessarily happen, but your voice matters, and collectively our voices will make a difference, even if it's just some money here and there. So go into those talking points, see the different pagers that we have. If you have any questions, feel free to reach out to me at any time. My email I am putting in the chat now, and we would be happy to talk more. The last thing that I want to highlight is that Dan and I have been waiting for the day that we broke 100 participants on a CTIPP CAN call, and we are at 135, which is way above 100. So we are pumped. Dan is fist bumping, and I can honestly say that in years of working with him, never seen him bump his fist before. So it's a good sign.
Congratulations.
So thank you all for being here and continuing to come. If you're not on the CTIPP CAN listserv, please feel free to email me, and I'm happy to put you on that as well, so you get the monthly notifications. But with that, I will turn it over to the wonderful Mimi Graham and all of our other presenters to talk about making your organization trauma-informed and how to determine where along the continuum it lies. Mimi?
Great. Thanks, Jesse and Dan. So we have a great program for you today. In 2018, we put together a showcase of 50 trauma-informed programs in Florida, and we simply asked folks to submit their program, and we didn't have any criteria, and we got everything from trauma-informed law enforcement to yoga in the jails to ACEs kiosks in pediatrician's office, and it was really awesome. And then Andy Blanche, who's also a CTIPP board member, and I were talking about updating that list in 2020, and she said, well, what criteria would we use? And so we started talking about there's SAMHSA criteria, and there's National Child Traumatic Stress, and oh, there's this tool and there's that tool, and you know, there's anything from a simple checklist to a full week audit that you can get to determine if your program is is trauma informed? And she said, well, what we really need to do is have a CTIPP program that would introduce and discuss several of these tools so we could make a more informed decision. So she put together the wonderful array of speakers that we have today. And we're going to do some speed dating. So you will we'll have 4 experts that will quickly describe their program. We know that this is not the all of the programs, all the tools that are out there. In fact, there are many others that we would love to have time to discuss at another time. We wondered if anybody would want to take on compiling the list of trauma-informed tools. If so, you can put your name in the chat, and I know Jesse will follow up. Or perhaps someone has already done that, like SAMHSA. But there's increasing legislation, like in Florida, we have brand new legislation requiring all judges, all dependency judges, to be trauma-informed. Well, what does that mean? And then, of course, there's the Family First legislation that really transforms child welfare, and it also requires, you know, programs to be trauma informed. So where's the accountability? What does it mean? And how can we all, everybody says they're trauma informed. And so we are so excited to hear from our experts and hear about their tools, so that we can make better decisions. And I hope somebody will take us up on putting together a compendium, and that perhaps we devote another one of our programs to the other tools. So without further ado, we'd like to start, and each of our 4 presenters have 15 minutes. So please stick to that so we can hear them all. So we're going to start with Marsha Morgan. So thank you so much.
Okay, Mimi, I'm going to, I've got the lawnmower people in the backyard right this minute. So I'm happy to get started here. Marissa, do you want to share your screen so we can move on? And know that that's a temporary thing. So I want to talk just for a minute about our trauma-informed culture assessment. And to Mimi's point, the question really was that we were trying to answer with this was, what does a trauma-informed organization look like? So Marissa, next, or I can't. So just very quickly, Resilience Builders is a Missouri-based organization. We are, we have a small team, and we have a number of independent contractors that work with us to make sure that we are stay tuned into the field. We have done learning collaboratives. We do on-site consultation. Mimi mentioned the residential children's facilities. We have been doing this assessment with our residential children's facilities for the last year to determine where they are on the continuum that we'll describe. So next slide, Marissa. So we created the trauma-informed culture assessment as part of the learning collaborative that we were facilitating. The question again for people is, why we're investing time, effort, money, and where are we in this work? It's probably worth noting that the Missouri Department of Mental Health in 2009 started to train organizations in being trauma informed. And again, Andy Blanche is our national consultant, and Andy's question has been, how do you know where you are? The Missouri Roundtable, keep going, Marissa. The Missouri Roundtable here in Missouri, which is a group of experts, created a continuum that we'll describe here in a minute. So the trauma-informed culture assessment is an employee-based assessment. It is very much the word of employees. It's all electronic, and we offer keep going, Marissa. That's where I want to be. So the employee assessment is taken by all employees. There are 48, and we'll get into this so you don't have to write anything down, but there are 48 indicators along the lines of the principles of safety, trustworthiness, choice, collaboration, and empowerment. We've added a dimension of sustainability because we recognize that this work is usually never, ever done. So the assessment comes to the employees electronically. They complete it. It takes 20 to 25 minutes or so. And after the assessment is completed, the organization completes a debriefing and then develops action plans to help move their organization through the process of being first trauma aware, then trauma sensitive, trauma responsive, and then trauma informed based on the, again, the Missouri model that we've developed here in the Midwest. So again, the 5 principles that as we've defined them, just so that folks know, the 5 principles include physical and emotional safety with the recognition, and we've incorporated equity, social justice, the issues around the isms into each of the principles. So safety looks at, again, social, emotional, and physical safety with the lens of power differential, systemic oppression. Trustworthiness talks about relationship, again, recognizing the differences that people bring to this work. That's true. Choice, and we look at choice from the employee's perspective, choice from the client's perspective, collaboration in terms of community collaboration, empowerment based on empowerment from staff to supervisor, with empowerment from a client perspective. And then again, in the sustainability section, really trying to take a look at what it is that will sustain an organization on the journey to maintaining being trauma informed. So if you think of this as a matrix, there's trauma aware, trauma sensitive, trauma responsive, trauma informed. That's our Missouri model. So the indicators align with those stages that we use here in Missouri. It is, while it's a Missouri model, we have thankfully also used this assessment in another state. And the other kind of fun thing is we developed a specialized version for restaurants. Because of COVID, the restaurants were not able to complete doing the assessment, but it just speaks to, I think, the flexibility that we have in designing the indicators for different specialty organizations. So when after the session is completed, you get an overall score, and there's some explanation about what is in the score. And then go to the next slide, Maris. And then you also will see in the assessment your top scores. When we work with organizations, we give them the top 3 so that folks are not completely overwhelmed. And then you also get, next slide, then you also get the next 3 areas of improvement that are absolutely needed to address. So you can see, just as you see the screen, small sample of the indicators. And from this, we do both celebration and action planning. The other report that's turned out to be really, really important that is available for folks are the no answer scores, because what we find out in the no answer is what employees don't know about what their organizations may be doing. We also find out from the employees and based on leadership, what it is that that the leaders think that employees know, but employees don't know. So then the other, besides action planning around trauma aware, trauma sensitive, responsive, and informed, the other action planning that ends up coming up is how are we communicating, and development of a communication plan. So Marissa, do you want to talk about the process?
Absolutely, thank you. And another thing that I'd like to add is that what we built into our indicators is really from a practitioner level of practice. And so that is definitely how we built the assessment and our indicators. And our process with the assessment is, so it is an employee-based assessment. We send out emails inviting people to take the assessment. The assessment time takes about 20 minutes max. We go through a process of not only inviting people to take the assessment, but we also send reminder emails. We coordinate with our partner organization that helps administer the assessment to do that. So this is a really timely process, but it also, we keep top engagement with who we've invited, making sure they stay on top of the invites and getting feedback if there's any technical issues around getting the invite to the employees. So after we take the assessment, Marsha Morgan and I have really talked about just kind of how we really get the organizations to understand the scoring, what this means, and action planning after. So we built in to the assessment, getting debriefs, going over what the assessment scores mean, what does that mean for leaders, what does that mean for employees, what does that mean for clients. We do that through debriefing, and we also do that through action planning. So anytime we take an assessment, we really highly encourage just those two within the debrief and action planning. We also have really learned since we've built the assessment, as far as other measures, we also invite people to doing site visits. So Marsha Morgan early on mentioned that we have done some residential work. One of the things that we've done is we've done an assessment and we've done a site verification and policy review with the residential facilities that really just adds on another measurement of, are we measuring safety not only but beyond the employee's perspective, but from a practitioner perspective as well. So that's kind of our process to that. As far as our privacy and security, our partner organization that we work with the assessment, it is, we did the security updates. It comes into the email. We make sure things are secure. The information is shared through a login, and we go through prior to any assessment. We work with leaders to identify who's going to review and have access to the assessment results. With that, all employee submissions to the assessment, they remain confidential. That was a discussion that we had in Resilience Builders and also with our partner organization, that we really wanted to make sure that people's responses remain confidential. Now that doesn't mean that the information that we're getting, we can also break down the assessment through a filter. And the filter allows us to break down information by department, age, sex, years with an organization, their familiarity with trauma. So though we're not getting, individual responses, we can even break down the information and the data that we're getting from the assessment. And so again, I just want to get to kind of the process is that not only are you getting an assessment, our process really is the debrief, other measurements through site verification and through policy review. We do the action planning. So yeah, so I don't know, Marsha, if you want to fill in anything that I missed, but.
I've been answering questions in chat. And so again, if there are questions come up, I think that best way maybe is to do the chat, is through chat. I will address the cost is determined based on the number of employees. We do, that is somewhat customized, because the more employees there are, the lower the per person cost, but the costs are figured on a per person basis. And we have had organizations as small as 12 and as large as several thousand, multiple state. So right now, our total number of organizations who have taken the assessment is probably nearly 40, I would say, and maybe even higher than that because of the residential facilities. Yes. And size of number of people in a department doesn't matter, really. You might have seen in chat that more than 3 people need to have taken the assessment for a department to get a report, but multiple sites can take it, and you can have an overall score. We have multiple filters. So the assessment can definitely be implemented in schools. We would, again, customize some of the indicators to meet the language of the school. So we would change client to students, that kind of thing. Yes, no, the agency owns the assessment, and the beauty of it is that you can, with multiple filters, you can filter by age, by ethnicity, by what department the person is in. So there's a variety of ways that you can filter the data and look at that. I'll give you a really quick example. In our second deployment here with our community mental health centers, we found that that the overall scores between race, white, Black, African American, Hispanic, Latino, were very, very similar. Not so for our Asian Pacific Islanders. They scored much lower in inclusion, belonging, feeling safe. So that is something that as a system we can address, for example. Mimi, I think I'm used up our time, and I'll just be quiet now.
Thank you, Marsha and Marissa. Thank you so much. And Jesse has a quick something before we talk to Steve.
I have a quick thing and a lot of sirens in the background, so I apologize for that, kind of like Marsha with the lawnmower at the beginning. But I just wanted to say, again, I am collecting all of these questions because of the list that we have going. We're going to need to move through, so I have a queue in case we're able to get to Q&A at the end, just so folks know keep them coming. And then I wanted to do a quick commercial because we have a lot of new faces that we haven't met before. If you haven't heard of the National Trauma Campaign, please click on the link when you get the chance, and we would love for you to join our advocacy efforts to make the United States trauma-informed and really work with a community of advocates to help promote trauma-informed and healing-centered changes throughout the country. With that, thank you, Mimi. I will turn it back over to you.
Thank you for that nice commercial for CTIPP. And now we're delighted to have Steve Kaufman with us. So Steve.
Thank you. I think we're going to find as we go through today's discussion that there is a fairly substantial amount of commonality across approaches. I thought what I'd do is start with a few thoughts about what makes for a good assessment in general, and then we'll talk about our particular model. First of all, let me also say thank you for allowing me to talk today. And you are well past the 100 participant now. I believe it's about 155. So you have met your benchmark, and meeting a benchmark is always useful for any kind of assessment. So we got involved in this process. I'm a member of faculty at Widener University, which is a small private university in Chester, Pennsylvania, which is right outside of Philadelphia. In the early part of, it's going to sound funny to say this, but the early part of this century, when our Center for Social Work took on a trauma-informed specialization, which has now become the dominant modality for our training of students. We have master's, undergraduate, and PhD students in our program. And in this process, we have 2 or 3 members of the faculty, of which a couple of them are on this call as well, with a substantial background in trauma work. Most of the work that we have done is related to the sanctuary model, and our association with Dr. Bloom, who many of you know, goes back many years. Many of the faculty, myself included, have been involved with a couple of research projects with hers. But where this sort of took off is in about 2010, we were contacted by the United Way agency for this part of Pennsylvania. The formal term is United Way of Southeast Pennsylvania and New Jersey. And they were working with Delaware County, which is a county of about 500,000 folks, which is where Widener is located. And there is a consortium of agencies across the county. They now have well over 200 social service agencies that are involved in some form of trauma work. And it became quickly apparent to them as they developed this consortium that many of the questions that we're attempting to answer in this discussion and things that you probably have been covering for several years in the larger discussions are as applicable for small agencies, for large agencies, and across the various practice domains. So we were asked to come up with an assessment process. And so what I'd like to do right now is sort of talk about what we try and capture, and then our application of it, and then describe it a little bit. So the general model is that any form of assessment that's utilized really needs to be quite comprehensive in approach. It needs to look at the assessment of attitudes, beliefs, the behaviors and skills of the participants, needs to look at the policies of the organization, needs the procedures and how they're implemented. And from that, you can begin to do some determination of what those needs and strengths are, which the previous speaker spoke to quite well. To that, I'd also like to add the concepts of leadership and the multi-constituency part of the problem, because no organization exists entirely on its own. It's always part of something more dynamic and more comprehensive, as well as the fact that, as you all know, and I think, again, the previous speaker spoke to this, is that the trauma-informed experience for an organization is a process. It is not a one and done recognition of, oh, yes, we are trauma-informed. Of course, you can show some numbers, and we do that, to say that you have reached some certain benchmarks, but those benchmarks have to mean something in the context of something else. So we have come up with some ways that we think are useful for achieving that. So what makes for a quality assessment? It's got to have some conceptual and theoretical grounding. It's got to have some reliable and valid measures. It needs to be appropriately targeted, and it needs to be comprehensive and participatory, meaning that you need, again, as many constituents participating in as you can possibly have, because people have different experiences. They see the world through different lenses. Which your clients experience and perceive is very often incredibly different from what agency directors and supervisors and line staff do. So we hope to try and capture as much of that as we possibly can. And we recommend for anyone that does this, that you take those into consideration as well. Further, there's this issue of interpretation, which is, again, spoken to previously, which is organizations evolve. And as organizations evolve, the things that change can be used both as benchmarks, but also as recognitions of points where targets exist, where change is necessary. Another thing that we recommend and think about is that the organizational domains are different, in the sense that what is fully appropriate, or even the language that's used for some kinds of organizations, is inappropriate to others. There are the universal principles that we all share related to what trauma-informed care means. But organizational communications are somewhat different in this process, and they need to be captured in some way. And then there's also the problem of the use of data. Why do you want to know? What's important about it? As we put together this presentation today, we wrote up a little blurb, and it was quickly identified that one of the big things that we hadn't put in the initial discussion was the fact that this is related to policy goals. We have both what organizations themselves need and their clients need, but also if we hope to achieve some sense of a trauma-informed service system, we need to understand how we can move toward and achieve that. So with all that as background, we came up with something called the Trauma-Informed Services Assessment Survey, or we call it the TICA. Again, this was funded by the United Way. It was developed by Widener University faculty. Two of the developers worked with Sandy Bloom, and all of the developers were sanctuary trained. It uses as its level of analysis the program rather than the agency as a whole, because you can have an agency that has multiple programs, some of which are much closer to attaining certain degrees of trauma-informed excellence, as opposed to others which are somewhat less effective at reaching those levels. So what we developed is a trauma assessment that is web-based. Currently we operate through subscription, meaning we work and contract directly with providers, but the United Way has also funded a developer who's going to open the system up hopefully by the end of the summer. It's hopefully by the first of the year, but that didn't make it. But by the end of the year, who's going to make the entire system that we've developed open to the entire community free of charge. Certainly we'll keep you all informed as the progress of that as we go along. Right now, it operates very similar to the previous model we talked about, where the amount that we charge is related to the number of participants who complete the survey. The most we've had in any one organization so far is about 45. We have worked with as few as 3 or 4, obviously for reasons of security and confidentiality. What we can do with the data is much different when you have 45 or 50 participants versus from what you can do with just 2 or 3. But then we aggregate the data by program, and we aggregate it by role in the organization if the numbers are sufficiently large. And then we report back a unique, currently we're doing it this way. Once we get to a fully web-based platform, it probably won't be this comprehensive, but we report back for the subscription, both the single item and index scores with an explanation of what the scores mean. We have a variety of indices, and I'll show you those in a moment, that are reported with comparative scores from similar programs in the service sector, geographically and by the size of the organization. And then organizations are encouraged to provide these reports to their presence trainer or whatever other system they're using for any kind of planning or coaching needs for development. We are not affiliated with Presence or Sanctuary or any other organization, but because of our long-term sort of affiliation of those and their various training approaches, we make the data available to the organization with the proviso that they may choose to provide it to their trainers or coaches, or keep it entirely internal for their own development purposes. So the survey we have is actually quite long. It takes the typical line employee about 40 minutes to take, which is, as everybody knows, is an insanely long survey, but it's very comprehensive. For someone who is in management, it might take even a little bit longer, maybe as long as an hour. And in it are a number of sub measures, indices, if you will. The list is here, which everything goes through, everything from TIC definitions to the degree of focus on ACEs within the organization, to their assessment processes, to their training and education procedures and provisions, all the way down to their policies for involvement and communication, etc. So when it's completed, you're provided a report that is quite comprehensive. Sort of the cover page, though, looks something like this, which has each of the indices, number of items involved in that particular indice, their particular scores and their comparative scores to, again, either the service domain, organizations of size. It depends on the specific needs of the organizations. Our material all of the indices have very high reliability assessment measures associated with them. The weakest of our indices has a reliability of about a 0.8, the most all the way up to about 9.96, 9.7. And our validity assessments are ongoing. We hope right now we have about 60 organizations and about 90 programs altogether that have completed the process. And we're in the process of doing our final work on some factor analyses to look at the final.
Steve,
Yes, sorry.
are you referencing a PowerPoint?
Yes, are you not seeing it?
We are not seeing it. I apologize. I thought that you were reading off a screen.
Oh, no, I pulled up my screen share on that. I'm sorry, it didn't show up.
Oh,
Can you see
there we
that?
go.
Ah,
Everybody in the chat that pointed that out, thank you so
please
much.
forgive me. Well, here it is. And I'll be more than happy. I mean, you've got this on recording, right? So
Yeah.
okay.
And we'll send the PowerPoint out to our listserv afterwards, so that way people can still reference it with the recording.
Sure. I am so sorry about that. I hit the share and for some reason it didn't take for whatever reason. So the joys of Zoom. Anyway, so again, we have something like 90 programs that have completed this to this point. And we're involved with 3 other organizations right now, each with about 30 to 40 participants per organization. And within that are 5 total programs. So by the time this is all done, by the end of the summer, we should have close to 100 programs analyzed. And the data will be presented. It's presented to the organization, similar to the previous speaker. It's presented to the organization. They have the right to do with it as they please. Most of them, however, are using it and sharing it with whatever outside consultants they have chosen to work with to help for their own internal planning purposes. Any questions?
He had
Just a quickie. When you said that you share comparative measures from other organizations, is that just in your universe of this tool?
Yes.
Okay.
Yes.
Thanks.
So the larger, I don't know if you're familiar with the Moral Foundations research that's done out of, I believe, Virginia Commonwealth, but they have a similar sort of system where they have a platform where people take the survey and then the data are reported out with various kinds of comparative analyses. And that's what we're shooting for. That's the final platform that we'll have by the end of the summer will look like that, with the comparisons that are available, again, based on geography or service sector or size of the organization. Right now, we're just doing it based upon largely on service sector because that's what we have the most data on.
Great. Well, thank you so much, Steve, for sharing. And we're glad to see your PowerPoints finally. So thanks so much.
I cannot apologize for that enough.
And no, we'll send them out. That'll be great.
Great.
So,
Thank you.
And next we have Steve Brown. So we'll change up the PowerPoint here.
All right, Steve, I think you need to stop sharing. There you go. All right, let me put my PowerPoint up. Can you hear me all right?
Yes, you're great.
Good. All right. There we go. So hello, everyone. Thrilled to be here from very warm Amherst, Massachusetts, and greetings to you all over the country, maybe even outside of the country. So I'm the director of a place called the Traumatic Stress Institute of Klingberg Family Centers. And I'm going to talk today about our measure, but in the context of our broader work that we do as well. So the Traumatic Stress Institute, our mission is really about supporting organizations and systems in their transformation to trauma-informed care. And we do so through consultation, professional training, coaching, and research. We have.
Would you mind putting it in presenter mode? Sorry.
Oh, I thought it was. It's
No,
not in presenter mode here.
no, we're just seeing all your slides.
Okay, let me do this
Thank you
again.
so much.
Yep, thanks for letting me know. And how about that? Yes, no?
No. It should be
So you're
the
good.
bottom
but
on the right.
If you, yeah, also if you go up to the slideshow on the top bar.
Yeah, I've been doing that actually.
Funny, it works for me.
Yeah, right there. Yeah.
Show present online.
It's usually the last little bottom on the right-hand side. You click it and
Nope.
Yeah, if you press just like from current slide or from beginning. Either way, that should open it up.
That open it up? Just did that. Nope.
okay, well, let's just go ahead.
Technology.
You have such a short time. We'll just deal with it. There it is.
Okay. So
Perfect.
we have two kind of areas of our core service. One is we offer a whole system change model to trauma-informed care, and then we do a lot in the area of trauma-informed care research. So in terms of our whole system change model, we have 18 to 24 month whole system change model that we offer to both organizations and systems that really begins with leadership engagement and planning all through foundational trauma training. We have a train the trainer model. We do significant coaching, and we provide ongoing professional education to our trainers all and do program evaluation throughout the whole process. We really have moved away from what we call kind of a train and hope model to a really fully comprehensive model. Currently, we have 77 client agencies that we support in 20 US states, 2 Canadian provinces in Jamaica, who are part of our international trauma-informed care kind of community of organizations. And in terms of our research, I'm going to largely talk about the attitudes related to trauma-informed care, the Arctic scale, which some of you may have heard of. It was developed by myself and Pat Wilcox at the Traumatic Stress Institute in collaboration with Dr. Courtney Baker from Tulane University. And the Arctic is a psychometrically validated tool that measures professional and paraprofessional attitudes, favorable or less favorable towards trauma-informed care. For those of you who remember your intro psych classes, sort of what psychometrically validated means that the measure has been gone through kind of rigorous study to show that it measures what you actually think it's going to measure. So we've published 2 peer-reviewed validation studies in 2016 and 2020 as validation enforcement for our measure. The Arctic scale provides an overall score and 7 subscale scores. There's a short 10-item Arctic, but then the comprehensive 45-item that provides all the subscales. And it's available in sort of pen, paper, pencil form, and also via a platform that I'll show you real quickly called the Online Arctic. And, you know, we were really trying to figure out what is a user-friendly model that can be done quickly, that can provide kind of data, robust data for organizations to see kind of where they stand, how they move as a result of an intervention, whether they sustain those changes over time. the scope of the Arctic, we estimate that there's probably been around 50,000 administrations globally of the Arctic by about 300 different entities all around the world. It'll soon be translated into 11 different languages, and it's widely cited in the professional literature. In terms of the subscales, we have 7 subscales. Here are the first 5. I'm not going to talk about all of them, but I'll give you a few examples. We'll talk about subscale 1. So subscale 1 looks at staff beliefs about what are the underlying causes of problem behavior and symptoms. And it looks kind of, do beliefs more in line with like problem behavior is adaptive, it's malleable, it's a survival skill that trauma survivors have learned that they're doing the best they can, or is there more of a belief that it's intentional, it's fixed, they know what they're doing, they could do better if they really wanted to, that kind of attitude. Kind of contrast those. So a sample item of subscale 1, and we set up the Arctic as a bipolar Likert scale. So there's a polar statements, one on the right, one on the left, and you fill out the bubble that's closest to your opinion. So this is clients could act better if they really wanted to versus clients are doing the best they can with the skills they have. That's a sample item in subscale 1. And I'll talk a little bit about subscale 7, which is for sort of staff beliefs about system-wide support of trauma-informed care. I think this is one of the most important subscales. Sample item, everyone is committed to working in a trauma-informed way long-term versus this emphasis on working on trauma-informed is just a passing phase. So this really looks at sort of whether the system, the staff believe that the system is really bought in, committed to this way of working versus sort of it's the flavor of the month, it's going to come and it's going to go. What do staff believe about that? And we have been working very hard in the last 3 years to develop a very user-friendly online platform for the Arctic. This enables people to administer it via computer, phone, tablet. People get, when they purchase this, they can get up to 8 time points over 3 years. It's a fully automated data management, and it fully automates data management and analysis so that, you know, we really work with a lot of organizations that don't have a lot of data sophistication or resources to put their data. So to have a thing that does all the work for you is really, really helpful for them in terms of them being able to actually do rigorous, robust program evaluation. And it provides a dashboard report both for the organization and a confidential dashboard report for individual staff members as well as recommendations both for organizations and individual staff about kind of improvement of their attitudes and development of their attitudes over time. And so these are just some of the questions that the Arctic can answer. Sort of where are we now at this current moment in respect to trauma-informed care? Have our interventions really made a difference? Have they moved the needle in terms of staff beliefs and attitudes? Of course, the idea here is that if we can shift attitudes, attitudes are related to behavior. And what we really are focused on is we want the moment-to-moment behavior of teachers with students, staff with clients to be different. Has it been sustained over time? Which job roles need additional training? These are all kind of questions that it answers. So I'm going to shift here and do a quick demo. Oops. So I lost my permission to share screen here. No, I got it back. All right. Can people see that? Can you see that? All right. So this is an example of the organizational report that you get with the Arctic scale. It has tabs along the top. The first 2 are sort of information heavy about introduction and description of the scale. This is the first tab that shows results. So this is an organization that did it at 3 different time points. And this overall summary score shows the first time point and the 3rd time point. And what's really great about this is that we are able to kind of show how the organization performs in comparison to a large representative sample of Arctic scores. So the bands in the back show sort of 3 different ranges. The light green is if you've scored in the 0 or to 25th percentile compared to our large representative sample. The middle band is 25th to 75th percentile. And the top band is 75th to 100 percentile. And if you click on any particular score, then you get to see all 3 time points, and there are recommendations in 5 different areas related to that subscale. What about in leadership and communication, hiring and orientation, training, supervision, and work teams? And if you go to the next tab, this is by department. You can designate departments. So this is comparing in this organization foster care with outpatient, with residential, with school in terms of their overall Arctic scales. Then it's by job role, by years in the organization. And then I'll go to the end and we have a kind of a curated resource list, which kind of the best resources that we found related to trauma-informed care in these different areas. So that just kind of gives you a little bit of a flavor about the Arctic, online Arctic. Let me go back to my PowerPoint here. Is that in PowerPoint mode? Is that in presentation mode? Yeah. So I just want to make a few comments about the kind of bigger picture of trauma-informed outcome measurement, because we've been involved in this since 2016 and really thought a lot about this. And, I think what we are talking about today, which is really kind of how do you know whether a trauma-informed organization or is an organization or system is trauma-informed? Incredibly important question. But I think this is really just the beginning, because what we really want to know ultimately is, so what, you're trauma-informed? Does being trauma-informed actually improve your service quality? And what would be the outcomes that would indicate that? So decrease in restraints, more positive interactions between staff and clients, reduction in school suspensions would be kind of outcome indicators there. But then, of course, really the holy grail is, does being trauma-informed really make people better off? These are, in some ways, that's the most important question, of which, when we think about it, what we're talking about today is really the easiest question the easiest thing to change, versus sort of making people better off in the long run has a lot of theoretical leaps and is probably the hardest to change. And in terms of when you look at the literature, while there are a lot of dollars being put towards trauma-informed care, I would say this question is that there's, there's some evidence about it improving quality of service. Much of it is very anecdotal and not necessarily kind of long-term robust studies. And I think there's really almost no evidence that trauma-informed care makes people better off. No robust systematic evidence in the literature. And so sort of I've dedicated my career to trauma-informed care, and I also am somewhat, I think it's a little bit scary about the number of dollars that are towards trauma-informed intervention without the research base to kind of to follow it. That research is way, way behind intervention. And I think when we think about policy advocacy, we should really be thinking about how we're advocating for research to catch up to intervention, or at least begin to catch up to intervention. And finally, I think, to make it even more complicated, we can think about measuring outcomes at these different levels. Sort of the person we're serving exists within a family, within a provider organization, within a service system, and within a community. And we can look at those 3 levels of outcomes about, is it trauma-informed? Are the services higher quality? Does it make people better off in all of these particular realms? And of course, wouldn't it be great if that the next generation, we could show outcomes that there's less referrals to child protective services, that ACE scores are lower sort of in the next generation of the people that we serve. So when we're thinking about how to look at outcomes, there's many, many different levels and types of outcomes that we can think about and look about in the broader as we begin to develop the research field around trauma-informed care. So, questions?
I think we're out. We'll need to save the questions for later, Steve, but thank you. And particularly for linking in the research and policy piece too. Those are really important considerations. So
thanks.
So now we'd like to turn it over to Jerry Vassar and Lori, is it Schreckengost? And we're so happy to have you all here today. Again, if you can put it in the presentation mode, yeah, that'd be good.
There we go.
Perfect.
Well, greetings, everyone. Thank you so much. Thank you, Marsha, Marissa, Steve, and Steve. Really valuable work, something that the field really, really needs. And we're pleased to be in the process of that. Now, what we're presenting is a little bit different in the sense that this is not a research tool, but an actually process that has been authored by Dr. Sandra Bloom. Her name keeps getting mentioned here today because of her long-standing work in the field, her ability to synthesize masses of information. Some of you know about all of her sanctuary books and her Sanctuary Institute. Several years ago, Sandy and I had a long conversation about the fact that Lakeside, I'm the CEO, president of Lakeside, Jerry Vassar is my name. And we've trained thousands of 40,000 professionals in trauma-informed care, but we all knew that we needed a more, we'll say, convenient, contextual, accessible, open, flexible approach to systems and organizations. And we'll let the folks that do the measuring, but we want to make sure that we're comprehensive in what we help organizations get to. So Sandy, after a long conversation, began to think about what it would look like to create today's research comprehensive program for organizations that builds on our past research, but now moves into this particular generation of organizations. And based on the fact that in working with 300 organizations, she knew there needed to be some changes and improvements in determining what makes an organization trauma informed. So she developed the presence model. That's an acronym that I'll talk about in a moment, but it is a very comprehensive, contextual, very flexible program for organizations to begin to embrace the idea of how do we become trauma informed and trauma responsive. And really to think about trauma as a central organizing principle. Often we think of our organizations in many different, I run an organization of 350 people or so, and we do all kinds of care for students and for systems. But often we think about it in terms of silos. And I think what we're trying to do is say, you know, if we're all dealing with so much adversity and trauma, those are the things that we have to look at as a central organizing principle so that our beliefs, our thoughts, some of the things Steve said, Kaufman said about how even assessments are to be done. We've got to kind of be a little more comprehensive in what we measure and how we do it. So we know that this is a paradigm shift for many systems, for many organizations. So you're really looking at your worldview, how you see the world. You're looking at the paradigm you're currently living in. You're looking at the mental model that you've kind of grown your organization and system around, how we think about someone or something, or what our attitudes are, and of course, how we deal with the behaviors that we're seeing every day. And understanding that when you move through a paradigm shift like this, these are the things that must be considered, evaluated, and thought about, and also provide some education for. So the idea behind the presence model is that not only are we thinking about trauma informed, but we're also thinking about trauma responsive, which goes to the skill level, and trauma resilient, which then moves us beyond this training and implementation process. So this is an acronym. Presence is an acronym, for the values that we believe undergird and inform trauma-informed practice. And we call it creating presence. Some of the objectives. We want the organization to all have the same knowledge. A lot of times language really means something, but trauma, adversity, and stress needs to be defined in terms of its impact. Let's see what just happened here. Okay. Then there is this idea of our values. We want them to be shared in an organization. We want the knowledge, practices, and skills to be a part of what we do. Trauma is a very complex topic. Treating it is even more complex. Dealing with multiple staff members is even more complex. So the idea is that we need deeper, richer, and productive conversations that incorporate the varied points of view that are necessary to build an organization that's trauma-informed. And then, of course, we want an organization that's aligned. You know, I don't know about you, but in my organization, I have certain departments doing certain things and others departments doing other things, and trying to get everyone aligned around this whole set of issues is quite an interesting dynamic to try to share values and do the things that we want to do. And then the inevitable result, we believe, in a trauma-informed and responsive organization is clarity. We know our mission now. We know our purpose now. We know our direction for our staff and for our clients. The acronym, I wish I could explain every term to you, but if I did, I would be in not 15 minutes, but 15 times 4 minutes. But Sandy's idea, and we know she's quite comprehensive in her thinking, it's about partnership and power, reverence and restoration, emotional wisdom and empathy, safety and social responsibility, embodiment and enactment. My slideshow just stuck here. Here we go. Nature and nurture, culture and complexity, emergence and evolution. Light topics, easy to understand, right? Well, it's embedded in throughout all the program in terms of how we do the educational process. We use a hybrid approach, largely on distance learning, so very web-based, and we also do our consultation process web-based. So there's no need to travel anywhere. This really worked out for COVID in terms of being really accessible, and it's accessible to the whole staff all at once. So that's the cool part. We believe this is a much more cost-effective model than other scenarios that we've seen. The organization itself controls this process. We don't. Self-help is what we offer, and of course, all the educational process. And of course, it's really determined organization to organization by the level of commitment they have. And the idea behind it is that when we get everybody in the organization on board, we're going to be successful. It's divided into 10-minute video segments so that we are sensitive to learning issues in many ways. There's self-check questions after you've taken a particular session. There are discussion boards where you can discuss it with your coworkers or use it for your own diary or discuss it departmentally. We try in this to take into consideration a variety of ways of learning. So there's supplementary videos, there's handouts for those who love to read, there's supplementary activities and other research for those that like to say, prove it in terms of what we do. So I think in the process, we're also thinking about continuous development. The program really starts with an introductory coursework for everyone. So everyone in the organization gets access to the learning platform, and they get introduced to presence, what healing transformation through values and skills looks like, the relevance of all the components of the acronym that I just described, how the model is implemented, and the 4 categories of trauma responsive skills, which I'll share in a moment. Also, we talk about attachment, stress, human stress responses, psychological health, pathways to healing, vicarious trauma, the typical topics that people all need to know about. And of course, we do a little bit of systems work. We think about what is it like for a system to function this way? What are the groups dynamic and what's the stress like in an organization? Because we know that often what happens to clients happens to staff, and what happens to staff happens to organizations. And of course, we want to identify some of our systems problems as well. And of course, Sandy has that 10 barriers to systems thinking that is all part of what everyone in the organization knows. After that, organizations split off, and here are the roles that we are concerned about. Obviously, these are organizations typically that have these 4 components. There's a leadership track. Often when we go out and talk to folks about their organizations, they ask us, well, why isn't the leadership being trained? Why aren't they involved in the process? So we have a leadership track, 42 segments. Again, these are those 10-minute videos I'm talking about. For clinicians, there's 42 segments. For direct service staff, those that are directly touching staff on the ground, 42 segments. And for your indirect service staff, there are 34 segments. The skills that we talk about are 4-fold: brain regulation skills, communication skills, group engagement skills, and complexity management skills. We believe that every staff member, relative to their particular role and function in the organization, ought to be engaging into these skills, which are embedded in the tracks and in the application and implementation process. Leaders particularly are talking about power and principles and policies. So when we talk about leaders, we want to align our attitudes, we want to align behavior, we want to align policy, and we want to do what we can to mitigate the organizational stress that our staff are experiencing. For clinicians, we want to talk about a specific framework for trauma clinical care. Of course, brain regulation skills are really, really important. We have skills for assessing and addressing trauma-related symptoms in the therapeutic relationship, so that you've been able to identify trauma symptoms in the midst of some of the things that you're seeing in a relationship with a client or with folks that we're meeting every day. And of course, the skills for supporting and coaching direct service professionals, since many clinicians supervise direct service folks. The course also provides definitions for direct service professionals. So what they're doing and their strategies and the way they're developing a trauma responsive milieu in how they deliver the services. And of course, then we focus as well on their skills. And those are the skills we just talked about, and how they promote growth through their clients, through brain regulation, group engagement, complexity management, and those types of skills. Indirect service, these are your people that run the organization or play key roles in the organization: your administration, your finance, your human resources, your food service, cleaning services, maintenance, public relations, security, development folks. All we think should be involved in the process, because we think it's important that everyone be aligned and understand what each other, the language that you're all using, department to department and person to person, and then staff to clients. And of course, the idea is to say they are equally important in shaping the organizational structure and organizational environment and milieu for how they handle everyday staff. We implement this, and I'll talk a minute about the enactment team, but we implement the process while all the staff are taking all this coursework. We do monthly video team meetings and consultation with what we call your enactment team. And that means a present staff member takes you through the process of how to implement this within your organization. And so again, it leads hopefully to certification, although people can take our coursework without the certification if they wish. And we want to get that anecdotal evidence. We want to make sure that everyone's taken the coursework. We want to see that the outcomes that we set at the beginning are actually happening, that the qualitative evidence is also there. So we want to do a portfolio of the things that we wanted to see happen in the organization. And the nice part of that is that each organization can choose the areas they believe are most important. And often we will use, we've already used the Widener program, the TICA program, to help organizations assess what they need. And of course, then we do a certification review and provide certification. It really happens with an enactment team within every organization, and they guide the implementation of the presence process to certification. We assume it's going to be around 6 to 8 people. I have one organization right now. It's a healthcare organization that has 19,000 employees. So we decided, well, they need more than one enactment team just to connect to the people that they want to do. So we can offer more cohorts for the process. But the idea is that this group of people will coordinate and communicate with our facilitator, with our consultant, and that will guide them through the process of how they interface with staff, how they interface with the information. So it takes, we think, around 18 months. We believe there should be an assessment and introduction process. Obviously, then we're doing the courses and the consultation piece. We are looking at implementation, monitoring the activities, the changes, the practical means, the policy changes, the things that go on. And then we go through the issue of certification. 18 months is a flexible time frame. Some organizations may take longer, and we're okay with that. As I said, we want to build it for what the organization can achieve. The portfolio is this interesting place where we have used that information to say, this is where you are now. But this idea of becoming trauma resilient is about community of practice. So what we want to say is this is not the end once you're certified, but the beginning. So we will continue to offer support, coursework, other aspects of what you need, additional coaching if you want to need it, so that if you want to do in your own community, you want to talk to people with your discussion boards and have dialogue, you can do that. You can do it nationally with other organizations that are in the present system, and you can do it internationally since we already have folks that are interested, and some are already on board in Canada and other parts of the world. So that's how you can reach us to get further information. Laurie Schreckengast is my associate. She will be glad to send you more descriptions, what the content is. And if you write to, you can go to our website, creatingpresence.net, if you want to see Dr. Bloom talk about the program. I have an interview there with her. And then, of course, if you want to do the info part, you can do info@creatingpresence.net, and we will be glad to get you more information. And I think I am through it.
Great. Thank you so much, Jerry. And what a lot of information you and everybody have packed into your 15 minutes. Thanks for everybody staying in your time frame. So that gives us a few minutes for questions. There have been such rich questions and discussion in the chat. Are there any questions we want for the whole group?
Yeah.
For any of our...
If you don't mind my running through some of the ones that I sort of pulled.
Yes.
So the
Thank
first
you,
one
Jesse.
I know that Marsha got to in the chat, but it was absolutely crowdsourced after I believe it was Mike Ritter asked the question, and then like 15 people were like, what a great question. So there is a large emphasis on quantitative assessment, but he was wondering how we effectively assess the life narratives, sensory experiences, and other qualitative elements that inform individual mental models and worldviews.
I'll speak to that briefly. We haven't applied such an approach, but the issue that you always confront when you're dealing with that kind of information is how to make the information generalizable across organizations. And for a particular set of benchmarks for a particular organization, it should be reasonably easy to develop such an approach. Where it gets interesting and difficult is to come up with a model that will allow us to look at a concept like trauma-informed care across multiple organizations in a comparative way. So crossing that bridge would be a wonderful bridge to cross. And I know that in some areas, not related to trauma-informed care, leadership, for instance, there's some research that's attempting to do that. And in the nursing domain, there's some areas of quality care for patients that have crossed that bridge. But I'm not familiar with one in the TIC area. And if anybody is, I'd love to hear it personally, because it's a difficult to come to common benchmarks across organizations. You can still capture the narrative, but what those narratives mean in any kind of comparative way gets to be really difficult. So,
and can I jump in quickly that I think it's a really good question, and I think it's also true that while we've addressed some quantitative issues here, I would suggest that the whole field has not really looked very much at quantitative issues at all. And that we have, as a field, have been very big on theoretical
Just about done, buddy.
theoretical papers, white papers, trying to sort of, apply the principles to different kinds of sectors, all of which is incredibly important. But we have so little empirical evidence to actually kind of support it. And so that, while we all, I think, have this amazing aha moments about trauma-informed care, and sort of it's meaningful, and we've seen it how it operates in our organizations, until we build an empirical base, I think there's going to be limitations to how far this field can go. So.
Thank you for that insight, both of you. Very much appreciated. And $1 million question, $1 million answers. Jerry, Lori, someone put in the chat that they were curious to know how translatable the presence model is for non-clinical organizations, such as educational or community-based orgs.
Yeah, I think that we have worked with all of those organizations at different levels. There's some organizations that are non-clinical and they would just not take the clinical track. We've had some organizations just want part of the training, and we have other organizations that want the rest of Lakeside's training that's applicable right to them. But we're really now, as you know, Sandy is more in the clinical care area, psychiatric care, varied organizations that have all these components. It is not a reason, though, that presence can't apply. We have a large presence in schools, and we actually have supplemental training that also go, because we run schools in a trauma-informed way, we do that as well. So we actually can come to clients with a full-orbed way of thinking about what they need. The important thing to know is, what do you need and how do we help you? And presence can be either a part of that or fully embraced in that. But no, it does not have to have a clinical department per se. Everybody has direct services. Everyone has, it just needs to be a little bit adaptable, which the beauty of the model is that when we do the coaching, you can adapt to whatever organization you are as we move through that.
Thanks, Jerry. For all of the trauma-informed culture assessment, or for Steve and Marsha, there was a question about how is there a focus within the work that you collectively do on cultural affirmation or consideration of how bias may influence the delivery of trauma-informed care?
I can go first, maybe, Jesse. And the short answer is yes. And again, it goes to both the assessment and then the ongoing consultation, and the visits that we provide. But within the assessment, you can filter information based on refresh them, on age, based on race, based on gender. I mean, there are many cultures that we want to assure feel valued and included, and that they belong in the organization. And then in terms of the ongoing work that we do, there's, and again, as we defined our principles included issues around power differential, systemic oppression, and the isms. So the short answer again is yes.
I'll jump in too. One of the reasons that our instrument is so painfully long is we have a very large number of items that try and assess a number of organizational characteristics. And one of the things that we look at specifically is the demographic composition of the organization, the demographic composition of their client base, and the demographic composition of their workforce and direct care folks. Now, that is not the same, absolutely not the same as true cultural sensitivity. It is a gross measure, but where you begin to see very large differences across those various constituencies, you begin to capture through the other questions in the survey where those issues of cultural competence begin to fall apart. So the short answer is yes. The longer answer is we can always do more.
And I think it's a critically important question. I think it's sort of been absent from much of the dialogue. One of the ways in an interventional level that we're trying to address it is that we have a foundational trauma curriculum that's been around for 20 plus years called Risking Connection, and we're developing a resource for all of our really 400 plus Risking Connection trainers around North America about how do you teach Risking Connection through an anti-racist lens. So how do you weave it into your examples? How do you talk about intergenerational trauma? How do you talk about sort of how whiteness, kind of people who live in white skin, live in a different world? How do you weave that into the kind of training that we do? So that's a part of how we're thinking about it.
Thank you. Thank you again for such deep and thoughtful answers. I got two more big questions. If that's all right, I think that we may go a little bit past 3:30 with them, and then we can open it up to the floor. But can each of you speak to how your tools have been validated, what the process was, and how you actually go about doing that, both on the training side and the measurement side?
So the Arctic scale was validated through an initial study that was done on about 780 folks, in which we gave a large number of items and narrowed it down to sort of the items that sort of fit together best, had some construct validity questions that were weaved in there. That was the first validity study. The second validity study that we just published in psychological trauma, we were able to draw on we had enough data from the Arctic, from using it for 4 years and from it being used with other measures. So we were able to do some validity about sort of when is there a relationship between the ProQoL measure, which is professional quality of life, and if you're higher in certain areas, are you, also kind of higher on your Arctic scores, and be able to do that kind of validation at a more comprehensive level than we're able to do in the 2016 study that was also published in Psychological Trauma. So that's a little bit about how we did it. I'm not the research brains, but so that's a applied psychologist version of the validity.
In the initial study we did in Delaware County, we did something similar to that. We also added what we call it's a discriminant analysis that looks at variation from concepts that are considered to be associated with trauma-informed care, and how close or far away they are from those. Those have not been published. They are on the to-do list for this summer. So we have essentially used the same method, and we put the flip side on it as well.
Okay, so I'm going to come in on the light side a little bit here. These guys are at universities and they're researchers and they're awesome. And I so appreciate all the work that they've done to lay that kind of groundwork. Having said that, the way that we work through this is we, again, used several different groups to validate the measures and to make sure that the measures were understandable to all different kinds of people, including clients, because in many systems, we know that our primary trauma survivors are also employees. So we also then did expert review, and we are now in the process of actually doing more work on validation and reliability. So again, we're not a university, we're a practitioner kind of group, and we're just continuing to do the work that needs to be done in order to validate all the indicators.
As far as presence is concerned, we have based a lot of what's done is a lot of evidence-based information that Sandy previously worked on. We've built on that, but we just launched in November. So we're still measuring, looking, and I'm the practitioner similar to Marsha. We're practicing what we're doing and looking at the evidence and taking notes and doing the research and using others like Stephen Kaufman to do assessments for us to let us know how effective we are. But we've just released in November, so we're not that far into the scenario, even though the research that's used has been pretty extensive.
Yeah, and just to say, Jesse, the indicators that were used were pulled from, again, like Jerry said, much of the work that's been done by our national experts.
And I think, there are more and more grad students, researchers that are interested now in trauma-informed care. I mean, people who are actually specializing in doctoral programs about trauma-informed care. And I think that we need to build relationships with those academic institutions in order to really use them to help us validate measures, create new measures. I think the more that we can do that, the better. And I think it'd be great if we had some more formal structure about how to link people doing research and practice in the field.
Steve, you read my mind on that one. We do need that. We do. And this is a good basis for that conversation. Sorry, didn't mean to jump in there, but
Always welcome people jumping on in support. This would not be the first time that we had a CTIPP CAN call that then spurred off into a separate subgroup that is then working forward. There was the CURE program, which was written about by Dr. Dixon in the chat earlier, that came from our January CTIPP CAN call. And so Steve and Steve, Marsha, if we want to put together a group to sort of start that process, we can, I see thumbs up, we can definitely start to look at ways to make that happen. There are other questions that I just don't think that we'll have time to get to, unfortunately, today. But Mimi, I saw that you shared something in the chat, so I don't know if you want to close it out before passing it back to Dan with your idea.
Sure. I just say what a rich discussion, and thanks to all of our presenters today. I think the takeaway for me is that we sure need a lot more research. And if any of these dollars can be cultivated with our partners at universities, that would be great. I know several people are on the call that are really working towards trauma-informed universities as a system, but also for the research opportunities. And then the policies also, we've got to have good policies that have meat in them that really, so we know what we're talking about when we say our programs are trauma informed. So I think we have so many more questions and so many more discussions that we want to have based on today. So thank you all for making it such a rich discussion. Dan?
Thank you, Mimi. Thank you, Mimi, for coordinating this, and the audience for staying with us through a very, very informative conversation. One last issue. Somebody asked about the American Rescue Plan Act being used. It can be used for a lot of the things we've been talking about. I doubt it can be used for research. It's really got to be used for implementation programs. But the kinds of programs, the presence programs, or all the other ones we heard about, I think could be funded. There are different pots of money. Some go to school districts, some go to local governments, some go out in grants from SAMHSA. So read the memo that Jesse sent out at the very beginning, and it will tell you where the pots of money are and how figure out how you could use one of those pots if you can access it to implement the programs we heard about. But I just want to thank everybody, our presenters, phenomenal, and I think we have lots of meat to dig our teeth into for future trauma issues at CTIPP CAN. So we hope you will keep joining us, and we're going to keep digging into all of the issues that you raised today. So thank you.
Thanks, everyone. Thanks to
Also, we also, Sandy Bloom is not with us. You were going to say something about Sandy and sending her cards,
Oh.
Dan?
Oh, go ahead, Mimi.
Sandy
okay.
is our president of CTIPP, and she's just had heart surgery. It must be because she has such a big heart and has done such a, incredible work in her life. And I'm sure she'd love to hear from you. Justin, can you or Dan put her email or text in the chat? And there have been so many references to her incredible work. She's been such an inspiration to us. So I'm sure she'd love to hear from us.
Thank you, Mimi. Shows your big heart. So.
Okay.
Thanks, everyone. I really appreciate the opportunity. Thanks to the other panelists. It's great. Really great.
Agreed. Thank you.
Jesse, Dan, I thank you. Becky Haas, I have not forgotten you.
James, you're always you're our best cheerleader. Thank
James,
you.
we love you. Thanks, everyone.
You're doing
Take
a
good
great
care.
job, gentlemen.
Thank you. We'll see you all in June.
All right.
Great.